and the recording and slides will be shared post-event. Next slide, please, Nick. And just to introduce ourselves as the primary care team at the Cancer Alliance, there's myself, Louise Roberts, Senior Quality Improvement Manager, and we've got Dr. Debbie Harvey, who is the CMCA and CRUK GP lead. So to begin the presentation, we're going to start with some key cancer stats, and I'm going to introduce you to Jenny Hampson, who is a performance analyst at the Alliance. Welcome, Jenny.
Thank you very much. Hello, everybody. Just to reiterate, just in case anybody joined late, we're asking if people wouldn't mind keeping cameras and microphones turned off, just so that we don't have feedback or impact on the bandwidth. So that will be really helpful. Thank you. What I'm going to run through today is some high-level cancer statistics and then a bit of a focus on prostate as well. So if you could have the first slide, please. Thank you. So in terms of a bit of an overall summary of what we'll go through, almost a quarter of neighbourhoods in Cheshire and Merseyside are within the top 10% most deprived areas of England. So we're already starting out from, if you like, a disadvantage. Our communities are already more impacted by deprivation than those in England as a whole. In Cheshire and Merseyside, that shows as 16,000 new cancer cases being diagnosed every year and around 7,000 deaths due to cancer each year. Our incidence is higher than England, which you would expect in an area with higher deprivation, so it's 5% higher, and our mortality is 8% higher than the England average. Early stage diagnosis is similar to England at around 53%, and we've done a bit of a calculation to what would be needed to achieve the 75% ambition for early diagnosis at stage 1 or 2 going forwards, and that would equate in real terms to around about 7 additional patients for each GP practice being identified with cancer at an early stage. Prostate cancer staging has remained consistent over the pandemic, so something positive is that it didn't become worse with later diagnoses due to the pandemic. That's a positive takeaway. Our 1-year survival has been improving over the past several years. We've gone from being below the England average to being very slightly above it. Having said that, what we see when we look at clinical commissioning group level is that the variety has widened between those different CCGs. So although we are overall doing better in England now, we do need to potentially address that inequality within our own clinical commissioning groups. We have looked at the COVID recovery versus before the pandemic. And what we wanted to highlight is that although most cancers have now recovered to the point that we've received more referrals than we did pre-pandemic, which is what we would expect normally to happen going forward, we have an uplift every year in terms of referrals. For urology and lung patients, we're still seeing a shortfall of referrals. So during the pandemic period, there have been fewer referrals in those 2 major cancer groups. Urology sits at 84% and lung at 81%, although we would highlight with lung that some of those patients will have been impacted by COVID because they already have respiratory complications, and then COVID obviously being a respiratory disease. Next slide, please. So here what we're looking at is a map of deprivation in Cheshire and Merseyside, with red being the most deprived areas and blue being the least deprived areas. And what we see is there is a real disparity in our patch. We've got areas such as Liverpool and parts of Wirral being very, very deprived at much higher averages of deprivation than in England as a whole. We're looking at 9 areas, 14 trusts, and that equates to around 2.6 million residents that we're trying to look after and serve. We've got a wide variation within Cheshire and Merseyside in terms of neighbourhoods. So in Cheshire, you only have about 5% of neighbourhoods in the top 10% most deprived, so better than the England average. However, you then go to Liverpool, you're at 49%, Knowsley 47%, Halton 32%, South Sefton close to 30%. So we see that very large disparity, and that's just something to be aware of in terms of that not everybody is serving the same community, and that feeds back to why people will have different rates of cancer incidence and so on. Next slide, please. Thank you. So this just reiterates the high level figures that I said before: 16,000 new diagnoses, 100,000 people living with cancer, 7,000 deaths a year due to cancer. Next slide, please. I will go quite quickly through some of these because there are quite a lot of slides. As I said, incidence in Cheshire and Merseyside is higher than in England as a whole, with Knowsley, Halton and Liverpool being among the highest incidences in the UK, in England. So that's of note that we are already dealing with a higher incidence of cancer, and you can see the chart with the disparity there, going down to Southport and Formby having a lower incidence. Next slide, please. You can vote this down to PCN level. This is off the fingertips tool that is available previously through Public Health England, and I always forget what the new department is called. You can see it ranges from Healthier West Rural having one of the highest incidence rates to Central Liverpool being one of the lowest. Now this is per 100,000 population, so it is comparable. But what it doesn't take into account is differences in the population structure. So, for example, some Liverpool areas have higher rates of student population, bringing the age range down. So you would expect lower incidence in areas where you've got a younger population. So it's not a comparison in terms of who should be having what incidence. It's more just to look at the range of incidence that does occur. And there'll be other slides that follow a similar pattern, and I take the same message from all of them, that each of these PCNs have got a different population, so would expect to see a variety of performance. Can we have next slide, please? Cancer mortality, as I mentioned before, is also higher than the England average. And again, we have Knowsley, Liverpool, Halton and South Sefton all being in the highest 5% of CCGs in England for mortality. So we know there is a challenge there. Could I have next slide, please? In terms of the long-term plan, there is this ambition for 75% of cancers to be diagnosed at an early stage by 2028. We are moving towards that, but we are, as I said before, moving towards it at the same rate as England. So if we were to achieve that target, we would be looking at an additional 7 cancers a year at each GP practice on average. And we see a range of early stage diagnosis, but it is not a large range. So we have between 53 and 56% early stage diagnosis. So we are all doing roughly equally in terms of early stage diagnosis, which is quite a positive to take away. Next slide, please. Here you can see the breakdown by the different types of cancer. So we are obviously particularly interested in prostate at the minute, which has a 50% early diagnosis stage. Breast has much higher at 85%, colorectal 40%, lung 33%. In Cheshire and Merseyside, we have tumours where there is a higher detection rate than in England as a whole: stomach, esophagus, lung and non-Hodgkin lymphoma. The tumours where we are seeing the biggest gap compared to the best performing cancer alliance in the country, cancer alliances, because it's not always the same one, are kidney, ovarian and prostate. With those, we are over 12% below the best cancer alliance in all 3 of those. Prostate obviously again being of particular interest. Next slide, please. Thank you. Looking at survival, we have 1-year survival here, and Southport and Formby of our CCGs have the highest survival rate, where Halton have the lowest survival rate. You can see the orange line being Cheshire and Merseyside moving from below the England average in 2003 when we started this chart to above the England average now in 2018. Obviously, Cancer Data runs very far behind, so we are currently looking at 2018 data for all of these high-level figures. Next slide, please. 5-year survival shows a similar pattern, although we've moved similar to the England average rather than above it for survival for 5 years. There is an ambition to reach 70%, and our current trajectory puts us at about 65% for that, so just below where we are aiming to be. Next slide, please. In terms of prevalence, we can break this down by PCN data. Now, this is QOF. So obviously this isn't a mandated QOF field, and there is variance in how much of it is completed by different practices. So we can take this as an indication, but I wouldn't take it as gospel. You can see a very wide range from 1.5%, 1.6% up to 5% of patients. And as it says, this indicator is evidence-based, but it does represent good professional practice to keep a record of those cancer patients. It helps us in knowing where they are, but there isn't that requirement for it. Next slide, please. This one again comes from Fingertips, and here we're looking at the urgent GP referral rates, so 2-week waits effectively. Here you see a range from around 5,000 to 100,000 population to 2,000, so less than half in some PCNs compared to others. In Cheshire and Merseyside and England as a whole, referral rates were lower in 2021. So here we're looking at 2021. I think we've previously looked at 2019-20, and what I wouldn't advise doing is comparing the two. We know COVID had an impact. We know there was a drop in referrals. What is interesting to look at is the disparity between the different PCNs during that COVID year. So we can see that it maintains that variance. Next slide, please. Here we look at them by tumour type, and we've highlighted urological because at this stage for referrals we can't actually split out prostate, unfortunately, from urology as a whole. It's only when they start to be diagnosed that we get prostate figures. We can see that there is a shortfall in urology. So this looks at what I talked about before. How many referrals have we had during the COVID pandemic compared to pre-COVID time periods? In things like breast and lower GI and skin, you see that is much higher. You see urology being at 84% of pre-COVID levels, lung at 81%, and also haematology is below that 100% level for referrals. However, that's very, very small numbers, which is why I didn't include it in the headlines, because you have such small numbers with haematology that you would see natural variation year on year anyway. Next slide, please. Here we again continue to look at urgent suspected referrals, but this is urology specifically again because we can't split out prostate, unfortunately. And we would say that there are around 3,000, we call them missing, so this is the difference between pre-COVID and now. What this doesn't take into account of is the natural year-on-year increase that we've been seeing for 2-week wait referrals over the previous 5 to 10 years. Generally for urology, it's been around 5% growth per year. Obviously, at some point that will level off. We won't keep increasing by 5% every year forever. But it's something that makes it more complicated, so we haven't included it in these slides. What you can see is the orange line, the 2020 dip, where referrals dropped right down in April and then started to recover throughout the remainder of that year. The blue dotted line is the baseline we're comparing against for 2019 data. And then 2021 is the green line that we see that referrals did recover. They were better than in 2020. However, they haven't really reached the 2019 baseline until we get to the very end of that year. If we look at November, December of the green line, leading into the little grey line of 2022, we start to see they're closer to the 2019 figures. But until we've got a few more months worth of data, we won't be able to say whether that's sustaining. Next slide, please. Again, this is conversion rates now. So we're looking at, for all those referrals, how many are converted into a positive diagnosis of cancer, ranging from Macclesfield having 9.3% down to Kirby having 3.3%. And we would expect to see again natural variation, but maybe less so than for referrals. Next slide, please. In terms of urology, for referral and conversion, you can see the orange referral rate going up as we see year-on-year increases, dropping in 2021 due to COVID. The conversion rate, you'll see, started out higher and then reduced as we had more referrals coming into the system. But what's interesting and positive is that the conversion rate has not dropped as a result of COVID. So we see it or increased, it has remained fairly consistent. So it looks like COVID did not impact on urological conversion rates. Next slide, please. In terms of where prostate diagnoses come from, we know that around half of them come from the 2-week wait pathway. Another 30% or so come via routine GPs. And this looks from 2018 to 2021. So what's interesting again is that COVID doesn't appear to have impacted on that. You can see that in 2021 we have a higher percentage of unknowns, but that would be more related to it taking time for the data to filter through. And we would expect that 6 months down the line, when we look at this because it's provisional data at the moment, but that unknown percentage would have reduced as more of the route to diagnosis data is input. Next slide, please. Also looking at it as a stage of diagnosis, what we see is that there hasn't really been an impact of the pandemic on this. We've got from 2018 to 2021 here. Again, it's provisional data. Again, we have a higher, potentially a higher proportion of unknowns. However, that should come down, as I said, with the previous one due to time. Next slide, please. And finally, just starting to look at staging and survival, we just wanted to highlight that for stage 4 of prostate, both 1 year and 5 year survival, the survival rate is much, much lower for stage 4 compared to the other 3 stages. So that's just the benefit of earlier diagnosis is very stark for those stage 4 cancers. Next slide, please. This just final note, this is where the PCN level data has come from. It's a fingertips tool, very useful to have a look at if you want to look at your own PCN data. Thank you. I'll hand over to Debbie now.
Thanks, Jenny. I know that some colleagues have arrived a little bit later than the start. It was just to advise that if you can keep yourselves muted and also keep your cameras off, because that helps with connectivity and all things IT. That's brilliant. Thank you. Right, next slide, please. So hopefully by the end of the session, you'll know how the Cancer Alliance can help you in Cheshire Merseyside. You'll understand the key requirements of the PCN DES, and you'll have some ideas as to how to get started. Thanks. So what we've tried to do in this presentation is to keep it as a pack. So once you have this presentation, you should hopefully have most of what you need. So there are lots of links and you can just click on those. Where we've used CMCA, that refers to us at the Cancer Alliance. This presentation is being recorded. We will share it and it will also be on our website. And there are also lots of resources specific to the DES listed in the NHS support pack, which is also underlined and linked there for you. Thanks. So why the ongoing focus on cancer? I mean, some of that has been alluded to in Jenny's presentation. So we still have the long-term plan and this ambition that we're trying to shift stage to 1 to 2 and aiming for 75%. And that in turn will help with 5-year survival. Primary care is really important because we can pick up early signs and symptoms, refer people into the system, and we can also encourage people to participate in the national cancer screening programmes. So there has been a lot of disruption from COVID. There is ongoing recovery. So really we need to look at opportunities to help ease the backlogs, ensure those that may not have come forward do come forward to seek medical review, and also help support prioritisation. Thanks. So in this year, our focus at the Alliance is to help support you guys and develop our cancer community of practice across Cheshire and Merseyside. That's been really difficult so far because of the pandemic, and it has meant that where practices and PCNs have been working on the cancer agenda, we've had perhaps less optimal sharing of best practice and new ideas, and perhaps of escalating some concerns and issues. And a community of practice is going to be key for us at the Alliance because it means that we can be more receptive to messages from primary care, and that will help our planning, encourage innovation and hopefully improve collaboration. Thanks. So this is basically a rough sketch of what things will hopefully look like. So these are our new plans for our primary care engagement team. So there's myself, I'm part funded by CR UK, and we have Louise. We are funding cancer leads at each place, and we're almost there with those colleagues, and I'll have a session a week to help with the interface with primary care and the Alliance. We are currently in the process of recruiting 3 Band 7 engagement leads. We have a Cancer Academy on the horizon, which is very exciting, and we're continually trying to develop our online resources on the website as well. So for those of you in PCNs, Over time, you will have a dedicated link person to the Alliance, and where we can, we will try to generate data for you. That's not always easy, as Jenny has already described. And hopefully we'll plan to help facilitate and coordinate communities of practice across the 3 main geographies of Cheshire and Merseyside. Thanks. So we're going to just touch on QoF briefly. Now, the important thing to note, and people may well have read everything already, so you will know, but there is no quality improvement requirement for this year. So effectively, there are no changes. So we're just going to recap. Thanks. So with regards to the cancer indicators, focusing as always on the cancer register, cancer care review, and there are lots of really good, helpful hints and tips on this on the Macmillan Cancer Support website. And there's the final indicator, which is the offer of support. Thanks. And cervical screening doesn't look any different, but there is a focus in the DES to increase cervical screening. Thanks. So moving on to the PCN DES. So the key principles are very similar to last year, but there are some changes regarding focus and there are some new areas as well. Thanks. So I've already mentioned this document. It's a really important document and has lots of ideas and tips and resources to help guide you through the DES. Thanks. So this is a bit of a busy slide, but basically in this year's DES for early cancer diagnosis, there are 5 service requirements. And broadly speaking, they include referral practice, they include cervical and bowel screening. The 3rd requirement is called adopt and embed, which includes both FIT and Tele Dermatology. The 4th service requirement is around prostate cancer. And the final and 5th requirement is around non-specific symptom pathways. So we're going to go through each of these in turn. Thanks. So service requirement 1 is about reviewing referral practice. And for those who were involved in the last DES and QoF QI, a lot of this will feel very familiar. So some of this may feel slightly patronising, hopefully not. So the key areas to consider in referral practice are firstly identifying early symptoms. So that's reflecting on NICE guidelines, and in this year's DES is also encouraging us to look at clinical support decision tools, which we'll go into afterwards. The second part is about ensuring appropriate assessments and diagnostics take place in primary care where required. And this will include simple things like examining patients and requesting necessary bloods. And having diagnostics completed or in process by the time a 2-week wait lands in secondary care can make a massive difference to what happens to your patient, particularly at the moment because 2-week wait referrals have consistently been about 20% above what they were prior to the pandemic. So the system, including ourselves, is very busy. The other element is using the right referral form, which we'll describe in detail afterwards, and of course the right referral route, making sure that the patient has been counselled and is supported in the process, looking at safety netting and learning from outcomes. Thanks. So the first step is to identify where you can make improvements. I think it's important to note that there is no set approach regarding this defined in the DES. The PCN can decide, so there is no set requirement for peer review meetings, although I think they should be included. So there's a bit of a free rein here. So I would suggest you look at what you did last year or the year before and see if you can build on things rather than reinventing the wheel. The DES does suggest focusing on patients in disadvantaged areas. So does that include your area? You may want to look at doing an audit, and that could look at suspected and recurrent cancers and routes to diagnosis. So you can make your own audit template, obviously, but there are some suggestions here. There's one that we've created at the Alliance, which is on the website. And there's also a pro forma that was used in the National Cancer Diagnosis Audit. Jenny has already mentioned fingertips, which can give some high-level information, and that might alert you to doing more specific pieces of work. You may look at learning event analysis for individual cases that you may have picked up, particularly if they've presented as an emergency or late stage. And the other thing you may want to do is to look at your GSF register. What do the cancers look like on there? Are there some later stage cancers or recurrence, for example? Thanks. So the next step is to agree which aspect to focus on, and it may include any of the following. So these are just some examples. So it may be about overlooked symptoms and late stages. Are there certain tumours that are being diagnosed more readily than others? Where are the gaps? Are there certain groups that we're missing? What do the intervals look like between first presentation and your 2-week wait referral? And what proportion of those 2-week waits result in a cancer diagnosis? And what do your routes to diagnosis look like? Are you getting a lot of emergency presentations? And are practices using any clinical decision support tools? Are people using safety netting, and are we monitoring our patients on a 2-week wait? And do you offer any support for your patients referred on a 2-week wait? So we're going to go through all of those in a bit of detail afterwards. Thanks. So what next? Once you've decided what you're going to focus on, you can then look at having a bit of an action plan. So none of this needs to be complicated. Ideally, it needs to be ongoing and continuous. And one of the suggestions in the guidance is that it may be that you focus on a couple of practices in your PCN if they're in a particularly disadvantaged area. So the work may be very focused. And as an alliance, as I've mentioned already, we're really encouraging PCNs to engage in cancer communities of practice so that we can all link up together and help support each other. Thanks. So we're going to move on to some resources now. So these are all for service requirement 1. So I've already mentioned the Cancer Alliance website. We're working our way through refreshing the primary care resources, and the only one which hasn't been changed as yet is the area on prostate cancer, but hopefully that will come very soon. Thanks. And as I mentioned earlier, we're developing the Cancer Academy for Cheshire Merseyside. And once this goes live, one of the focus areas will be on primary care. So this is really exciting and will hopefully help primary care to feel better supported with regards to education around cancer. Thanks. So we've already mentioned fingertips. There's the link at the top left-hand corner there. You don't need to register. It's publicly available data. My criticism of it is it's a little bit on the old side. It is due to be refreshed, I think, for June, but it does give you some high-level data, and you may look at it and say, gosh, we're outliers in that area, and that may then encourage you to have a bit of a deep dive. Thanks. Okay, so I think Kathy's on the call, but I think Kathy needs to skip off to another meeting. But Kathy Hubbard is a colleague who's a GP over in Liverpool and is also helping to support this piece of work at the Alliance. Thanks. So this piece of work is around developing templates in the clinical system, and this will hopefully help all of us involved in 2-week wait referrals, not least the poor patient. So NG12 criteria are included in these templates that have been developed, and local guidance can be accessed at a click. So it's all there in front of you. There'll also be other prompts to help your patient and looking at checking your awareness of reason to refer, contact details and special needs. There will also be reminders including relevant examination and pre-referral test, and that's really just to help speed up triage for your patient. Also including performance status and, if appropriate, frailty. And after discussion with the patient, that then helps foster a bit of a realistic expectation of the referral if that patient is very frail. And the quality of the referrals is hopefully therefore improved and helps with the PCN DES. And there are also safety netting code prompts as well. Thanks. So this is a screenshot of what it all looks like on EMIS. So basically you click on the 2-week wait protocol and then you have a bit of a pick list. Thanks. And then as you open that up, this is what will be in front of you. So there'll be links to resources, there'll be prompts to encourage you to include all the relevant information. Thanks. And there are some additions which aren't in the current 2-week wait documents, including diagrams and the request for some additional information. Again, this will all help triage the patient. Thanks. And then there's a bit of a pick list. So this is what it looks like in EMIS, and it enables you to code certain areas, but also takes you to other areas of the system, for example, the referral form. Thanks. So we have a guidance over in South Sefton, as they do in Liverpool, regarding breast pain, for example. And these things are really, really helpful because you can use them with your patients sat by you to explain why you're doing certain things. And it's also a bit of a prompt for us to remember what the pathway is for breast pain so that we don't automatically refer the patient onto our colleagues in secondary care. And also with this system, you can link to websites with leaflets to give to patients, which you can adapt locally. And if you decide, having gone through the process, that your patient doesn't meet the 2-week wait, it will still record the consultation. So basically looking for early adopters to feed into the final versions. So if this is something that you're eager to get involved with, then please contact Kathy directly. That'd be fantastic. Just been told that the email doesn't look quite right for Kathy, but you can email us and we'll certainly contact the right people. Thank you. Thanks. Okay, so clinical decision support tools are varied and not everyone likes them, and it depends on what you like. I'm quite a visual person, others will like a bit more of a narrative. So one of the clinical decision support tools which is promoted is one called the Cancer Maps, and you can find this on Gateway C. Thanks. And another another CDS is one that's been created by Cancer Research UK. So this one is less pictorial than the last one, more of a narrative. So you basically choose what suits you. Thanks. And then for your patients and signposting, I think many of us now have a patient support letter on our clinical systems, which can be adapted for local use, and that can have local numbers for Macmillan contacts. There are resources on the CRUK website, as underlined there. Printing off the booking details can be useful because that will have the contact details for your patient in case they're not contacted within a certain framework, time frame, I should say. And you may want to look at creating local resources online. And I think increasingly, as we have ours in PCNs, people are also tapping into social prescribers and community navigators, perhaps for those patients who need a bit more in the way of support. And accurate text can also be really helpful in supporting patients and perhaps giving web links, etc. Thanks. So safety netting, obviously this was highlighted in the last DES, and that was very much focused on 2-week wait referrals. So safety netting has become increasingly important because certainly from where I work, our patients are becoming more and more complicated. We're doing more investigations in primary care. And the other thing I think which is more of a challenge is continuity of staff, and also staff who perhaps work part-time. So practices will have some familiarity with safety netting, as I mentioned from last year. There are lots of resources regarding safety netting on the Cancer Alliance website, including the template that we have developed locally, which is being updated. I think I would say, to practices, it doesn't matter what you do for safety netting, but really it does need to be IT based, and it needs to be used by the whole practice and you do need to have inbuilt regular checking mechanisms as well. Thanks. Okay, so all of that was around service requirement 1, which is referral practice. So we're going to move on to the remainder of the service requirements, which aren't quite as lengthy. So the second one is about improving cervical and bowel screening. So cervical screening, there's an interactive resource, the link is there, which is quite useful. And as we've mentioned already, we have fingertips, although the data on that is a little bit on the old side. So some suggestions in the guidance include building on what you've done previously. You may well have done some groundwork already, focusing on one low participation group, auditing non-responders to see why is it that they don't respond. And you may then have a very specific targeted approach for that cohort. Increasing contacts for non-responders. It may be that having 3 goes isn't enough and it needs more. If there are larger initiatives, get involved. And the other suggestion in the guidance is to see if there's some collaborative working that can happen with commissioners to increase cervical screening clinics. And just to say that at the Alliance, we're working closely with our colleagues in public health to see how we can improve the data that's available to primary care. Thanks. So service requirement 3 is called adopt and embed. There are 2 parts to this. The first is fit, and I've put in red incentivized. It is the only part of the PCN DES where there is direct enhancement or money. So just to recap, fecal immunochemical testing, or FIT, in symptomatic patients works as a triage tool for us in Cheshire Merseyside, and it supports prioritisation of colonoscopy capacity so that that is targeted at those at greatest risk of colorectal cancer. There's a massive backlog for colonoscopy, and that is why FIT is identified as priority in the operational planning guidance at NHS England. So requesting a FIT at the time of a 2-week wait referral for those patients, importantly, who do not have an abdominal or rectal mass or rectal bleeding, helps ensure that secondary care receive a timely result, and then that helps them to triage the referral and prioritise. So at this time, we're not asking practices to wait for the FIT results in order to proceed with the 2-week wait referral in high-risk patients. That's an important point at this moment in time. The patients who fall into the DG30 group will already have their result. Thanks. So the IIF for FIT is focused on the FIT result. Okay, so it's going to be really important to encourage your patients to participate in the submission of their samples at the point of referral so that you increase and improve the proportion of subsequent results, remembering that this excludes patients with an abdominal, rectal mass or rectal bleeding. So you may want to use text reminders, you may want to have some kind of safety netting in practice to track and trace, or you may want to develop some local information. And there are some other resources available online. The other important thing is when you make that 2-week wait referral, you need to make sure that on that referral form that you've indicated if there is no FIT result, that you've ordered one. Hopefully in most trusts they'll be able to see that on the shared IT systems for the labs. So just looking at the IIF in a bit more detail, this is basically what it says. So it's the percentage of lower gastrointestinal 2-week wait cancer referrals accompanied by a FIT result, with the result recorded either in the 7 days leading up to the referral or in the 14 days after the referral. So for this year, PCNs have to achieve a minimum of 40% in order to get the payment. The upper limit is 80%, and next year the 40% goes up to 65%. So I would suggest that of all the service requirements, that this is the one that needs the most urgent attention, because if you leave it for several months and then you find out practices aren't using FIT, it's too late. And we've included the relevant codes at the bottom of this slide, noting that for the IIF, it's only the result that will be monitored. Thanks. So the second part of service requirement 3 is Tele Dermatology. And really for this, unless it's available in your area, don't worry about it. And the idea here is that Tele Dermatology increasingly has been shown to be really effective. And so if you have it locally, it's about raising awareness and making sure that people use it. Thanks. So service requirement 4, there's a focus on prostate cancer. So I would say out of all the service requirements, this is the trickiest one, and that will become clear shortly. So as Jenny mentioned before, nationally, treatment numbers for prostate cancer have been the slowest to recover, along with numbers of referrals for suspected prostate cancer. So the guidance is basically asking us to focus on this area, looking at data, and if the data shows that referrals haven't picked up, is basically to try and get them back up. Thanks. So as Jenny mentioned, it's actually quite hard to get this data. So practices can access the ERS Open Dashboard if they use ERS. This gives you CCG level data around 2-week wait referrals. But as we mentioned before, this will only give you 2-week wait referral numbers for urology. It doesn't split it off so that you can see prostate, but it'll give you a little bit of a guide as to what the referral pattern looks like. Thanks. So this is a really important area just to touch on. So to check or not to check the PSA in men with no symptoms. So if you've discovered that your referral numbers haven't picked up, so what I've done in my practice is we've basically done a 5-year search for fast track urology referrals over the last 5 years. And what that has shown, bizarrely, is that our referrals for urology actually have gone up across the pandemic for whatever reason. So it's hard to know what would we do if the referral numbers were really low. And I think the other thing also to mention is that if you're in a very large practice, it's very hard to know if the numbers have gone up or down because the numbers will be quite small relatively. However, if we look at PSA in men with no symptoms, we have to be really careful. It's a Pandora's box. And I looked at the Gateway C module, which looks at this area last week, and it's a brilliant module. So if you are wondering about doing opportunistic PSAs in your male patients, think twice. Have a look at this module. And it will explain how to manage these situations. So, you know, men at 15 above are quite within their rights to request a PSA. However, it's not without issue. So the links are there for this particular module, and there's also a module around symptomatic prostate cancer, which is also very good. Thanks. So this slide just highlights why PSA in asymptomatic patients is a very tricky area. So the first thing to note is that PSA is definitely not a screening test and absolutely should never be added to routine health check blood requests as part of an MOT. Mustn't do that. If patients request a PSA, they absolutely must be cancelled, fully informed of the risks of false positives and negatives. So 75% of men with a raised PSA level will turn out not to have any kind of prostate cancer. And the issue is that even with investigations, there is significant morbidity. So there's a balance between doing more harm than good. The other thing to notice also is that we can falsely reassure people. So 15% of men with a normal PSA will actually have prostate cancer. So although you may well detect cancers in asymptomatic patients, if you look at the research at this moment in time, it doesn't actually save lives. So if a man asks for PSA, just make sure that they are fully counselled of the pros and cons, make sure that that's in their notes, and that they don't feel falsely reassured if that PSA comes back as normal. Thanks. So the final service requirement 5, is the use of non-specific pathways. So the review of non-specific symptom pathways is basically to look at opportunities to increase referral activity, and we refer to these locally as non-specific RDS. Thanks. So what is a non-specific RDS? So basically, these pathways provide an entrance for us into secondary care for those patients who we think may have cancer, but they don't meet the criteria for NG12 for all the other tumour pathways. But importantly, these patients have symptoms which are unexplained. So we absolutely need to look at other causes first, and exclude those causes before we define the patients as having unexplained symptoms. And then the referral is processed in exactly the same way as a suspected cancer referral and is aligned with the national standards. Thanks. So where are the non-specific RDS in Cheshire and Merseyside? So they're listed here. Not everyone has one, but if your area is not listed there, there will be one soon. And this slide highlights the key people at those trusts who you can contact with general inquiries, not patient specific, please. And also the key link at the Alliance is Sarah Griffiths, who's very happy to receive general inquiries. Again, mustn't be patient specific. Thanks. Okay, so this slide will help us look at the referral criteria. Thanks. So the first is new, unexplained, unintentional weight loss is a criteria, ideally documented, but there is an acceptance that because of the pandemic, certainly as in primary care, haven't been weighing people to the same degree as we did previously. Thanks. Another criteria is unexplained constitutional symptoms of 4 weeks or more, less if very significant concern, and this can include loss of appetite, fatigue, nausea, malaise, bloating. Thanks. Another criteria is unexplained vague abdominal pain for 4 weeks or more, and less if very significant concern. Thanks. Also new, unexplained, unexpected or progressive pain, and that can include bone pain of 4 weeks or more. Thanks. And the final one, which is a really important one, is gut feeling of cancer diagnosis. And if there is a gut feeling, you need to describe what that gut feeling is. Thanks. Okay, so looking at the core tests. So these core tests are really important to help exclude other causes, because what we don't want to happen is for patients to end up in the wrong place. So these are very much baseline tests, which we'll all be familiar with. Next, and these are optional tests, which may be relevant depending on what the patient's presenting with. Thanks. And next slide. So in summary, there are 5 service requirements in the PCN DES. Referral practice, cervical and bowel screening uptake, this area called adopt and embed, where we've highlighted fit because that's linked with the IIF and needs some quick proactive work, and also Tele Dermatology. The 4th regarding prostate cancer, which as we've explained is a very tricky area. I think probably I would, given we have data issues, I'd probably recommend practices do a search on EMIS to get a bit of a feel as to what things look like. And if you've noticed that your referrals haven't picked up, then perhaps look at education so that we make sure that colleagues are alert to the criteria for NG12 and suspected prostate cancer. And the final and 5th service requirement is looking at referrals to non-specific RDS and making sure that colleagues are aware of those services if they are up and running locally. Thanks. So next steps, these are very much suggested. So I think what I would do as a PCN lead was come up with a brief overarching plan and priorities for those 5 service requirements, because some are more important than others with regards to timeframes. The next would be to create some time slots, regular time slots, so that we can keep everyone up to speed. And certainly if we're monitoring those fit numbers, is to work with practices if they're not at the 40%. And I think that bit's really important because peer reviews are not mandated as part of the agreement in the DES. The fourth bit would be to engage, so get to know your local communities of practice, and we will do our best to link in with you. And as we said, we're recruiting staff at the moment, so hopefully you'll have a named person in time. And the last one is to access the resources we have on the website. And if they're not the right ones, please let us know. Thanks. So as I've just mentioned, once we have our full set in the primary care engagement team, we will contact you all. There are going to be further webinars across the year, and we'd welcome ideas for those. Just mentioned the resources on the Cancer Alliance website. And as I mentioned earlier, we're developing a Cancer Academy. And again, we'll let you know as soon as that goes live. Thanks. Okay, so that leaves us a few minutes for any questions or comments.
Thanks, Debbie. Thank you to Jenny and Debbie for some really interesting and informative presentations there. We did have one question in the chat box around the IIF requirement for FIT, but Bev has answered that question.
Oh, thanks, Bev.
And so it's just to say, if anyone does have any questions, please pop them in the chat box now, and we'll ask them.
Yeah, we'll stay until 2, but if other people want to leave, obviously you can, but please feel free to ask any questions, or you can email us directly. That's not a problem either. But thanks everyone for joining us this afternoon, and thanks for everyone's help.
Thank you. So yes, the slides will be shared post webinar along with the recording as well. There'll be a link sent out to all attendees.
Sorry, could I ask a question, because I seem to be having some problems with my typing. If you've got the option of Tele Dermatology and not everyone in your PCN takes it up, will you be punished?
No, sorry, I'm trying to unmute myself there, Jill. No, not at all. It's not being, none of this is being monitored. It's only the fits that will be monitored. There's no template for people to be filling in. That's my understanding, but happy to be corrected. But I haven't seen anything in what I've read that's said that anyone would be, monitored in any way. I think it's about encouraging best practice. That's my understanding.
Yeah, thank you.
Is that okay?
Thank you.
There doesn't appear to be any more questions coming through. Just a lot of thank yous.
Debbie, can I just ask you, with the you mentioned the figures around prostate.
Yes.
With the advent of MRI scanning for prostates now, are the figures for morbidity the same as they were previously? Because I thought that the threshold for screening patients for PSA testing were the figures were actually better because of the advent of MRI scanning as opposed to prostate biopsies. Is that not the case? Am I wrong?
Yeah, I think you're right. I think moving forward it will be better. But I think the research is as up to date as it is, isn't it? And certainly the GP who advises CR UK, who I work with, based on the current research, even if we don't look at the morbidity, we're not saving any lives by checking PSAs in men with no symptoms who have a raised PSA. It's a really difficult and contentious area, and I think as GPs the best we can do is that if men ask if they can have a PSA, we just need to make sure that they're fully counselled and are made aware of the pros and cons, and then leave it to secondary care colleagues to take things forward. So it's a really difficult one, and I think it's the hardest of the service requirements to know how to manage for the good of our patients, to be fair. So but yeah, I completely take your point. I think with the diagnostics that colleagues are starting to use, the morbidity aspect will be less, but actually if we look at outcomes for lives saved, I'm not sure that will change, if I'm honest, but I don't know. Does that help at all?
Yeah, no, that's fine. Thanks very much. Thank you.
Thank you. Jill's asked us, there's a patient info sheet on the website. I'm pretty sure there is, but I'll double check, Jill.